Thankful for your kind introduction. As we know that diabetes is not a very new disease, it's very old, and there is a advancement in the treatment of the diabetes. Like the Dr. Ali was saying that I was sitting in a very modern car and he was sitting in a car of 1956 or 1856. Have you seen this car in the road right now? Yes. Oh, thank you. So there are more advancement in the management of the diabetes as well uh, from time to time. And we know that these SGLT2 inhibitors are the advancement in the diabetes. And we sometimes consider ourselves unfortunate that we get these medications late in our country. But I think we are fortunate because this has been tried a lot for many years outside in our country. And when it comes into our country, we know all the side effects and the risk factors associated with these medications. So then we can use very cautiously in these patients to avoid the side effects as well. Why we are treating diabetes, Dr. Ali elaborated very well. To control the diabetes is not the number of controlling the number of HbA1c and the fasting and the random blood sugar, but for the prevention of the acute and the chronic side effects. But the advancement of in the diabetes management is made to further reduce these complications in the diabetic patients. So before I came here, I was confused about this subject. Having listened to your lecture, I am still confused, but at some higher level now. Okay. What we do when we use the communication of the medications, our aim is effectiveness. These are well tolerated. The durability of these medications, either they are durable for the prolonged period or not, or they are only for the short period. We will see it better. The cardiovascular and the renal protective effects, whether they are protective for these organs. And up to 2009, the FDA and the other ADA guidelines restricted to produce the medications which have a cardiovascular or the other organ damage beneficial medications. And weight loss, if someone can lose weight, he can go to remission and can get rid of the medication he is taking. Oral once therapy, adherence can be good, whether it's cheap or not. If you are talking about the SGLT2 inhibitors, if we compare the cost of our country with the Western and the UAE, we are getting these medications very cheap here, like at the same price of the modern sulfonylureas we are using in our country. Oh, last but not the least thing, Dr. Ali has stated the studies of all the European and the outside countries. But what about the local studies, whether it is available or not for this particular salt or not? So thinking about the efficacy, I will not go into detail how it works. Everyone knows that the SGLT2 inhibitors leads to increased glycosuria. By this means it reduces HbA1c, weight loss, and by creating more sodium, it leads to improvement the hypertension, and by reducing the glomerular hyperinflammation, it can lead to reduce albuminuria and renal protective as well. So this is a meta-analysis of the SGLT2 empagliflozin in which it was compared with many medications in the pool, with metformin, with sulfonylureas plus metformin. In all cases, they showed a significant improvement of HbA1c from the baseline from about 0.6 to 0.8% in some studies. When whether the SGLT2 inhibitors are durable or not, in 102-week study, the SGLT2 dapagliflozin was compared plus metformin was compared with the glimepiride. After 102 weeks, if you can see that the HbA1c was reduced by 0.8%, while if you look at the metformin plus placebo group, the HbA1c remained static and very mildly even it was increased. So This is our now very recently 2 days back published study on 28 June 2029. It was a cohort study done in the US Department of Veteran Affairs, where they enrolled a total of enrolled a patient who were taking the metformin. They started in 23,870, they started SGLT2 inhibitors, and in 104,423 patients, they added sulfonylureas in this group of the patients. So what was the outcome? The patient who was diabetic taking metformin, by adding by adding SGLT2 inhibitors was associated with increase was with reduced risk all cause of mortality compared with the sulfonylurea. And this is a real life study data. So if we talk about the weight loss, if you can see that 100 milligram of canagliflozin was leading to 4.3 kilometers weight loss, and the 300 milligram was causing 4.4 kilogram weight loss over 102 weeks. And in this, the SGLT2, the canagliflozin was compared with the sitagliptin, the 100 milligrams and the 300 milligrams. In both arms, it was causing HbA1c reduction and weight loss in both of the arms, while the sitagliptin was causing some HbA1c reduction, but it was weight neutral. So the reduction effect on the blood pressure is obvious. If you can see in the overall population, the 100 milligram was causing 4 millimeter, and the 300 milligram was causing 4.7 millimeter of mercury weight blood pressure reduction in the overall population. But in patients who had already raised systolic blood pressure, that is the blood pressure greater than 140, they was causing more weight loss reduction in the blood pressure. That is 6 and 7.4 with 100 and 300 milligram canagliflozin respectively. So here comes the first local study, which was done in the Islamabad by our endocrine colleagues. What they found, there was weight loss of 1.98 kg, HbA1c reduction of 1.1%. The systolic blood pressure was reduced by 2.8%, and the diastolic blood pressure was lost by reduced by 2.02%. So this is the landmark, remarkable studies which our senior Dr. A.H. Amir explained yesterday very comprehensively. And this is the first landmark randomized multicentric study in our region, which showed there was significant HbA1c reduction in both arms of the patient who are receiving the empagliflozin and on the other group. The fasting blood glucose level was significantly not remained the same in both arms. So now about safety. We know that the SGLT2 inhibitors are beneficial by cardioprotective risk reduction, renal protection, decreasing blood pressures, and it can be used with other medications like insulin. And there are some concerns about urinary tract infections, increased genital infection, potential of volume depletional effect on the bone health, the ketoacidosis, and question mark decay. Because in only one study of canvas, it shown that the amputation rate was increased with the use of a canagliflozin, but the subsequent studies failed to show this association. If we talk about the hypoglycemia, with glimepiride in the dapagliflozin plus metformin, there was only 3.5% risk of hypoglycemia. While if you can see in the glipizide group plus metformin, there was about 41% risk of hypoglycemia. And you know that once hypoglycemia occurs, it can be lethal for the patient, and the patient can be admitted. And everybody knows that once the patient admitted for one time, how much cost he bears, it is only known to the patient and their family. And similar for the cardiovascular events, If the patient developed event of cardiovascular events, the patient will suffer finances of millions, and similar for the renal outcome. The genital tract infection, yes, there are some concern about the genital tract infection, and we can avoid these by giving to the patients who are not prone, of course, by taking a good history. This was a study from the randomized control trial in dapagliflozin causing the 4.8% genital tract infection and UTI of 4.3%. In the placebo group, there was a 3.7% of the UTI. The difference was less than 1%. You can see in this randomized control trial of 12 studies. This is the safety data of SAFE-PARC study, in which they have shown significant safety effect on the adverse effect. In the group B, there was significantly higher risk effects as compared to the patient who was receiving the empagliflozin. The hypoglycemia risk were lower as compared to the other group. The dehydration was same. The hypotension was more in the other group who are not receiving on the empagliflozin. And the positive urinary culture, very importantly in our part of the world, the positive urine cultures were more in the other arm who are not receiving the SGLT2 inhibitors. And interestingly, the fungal infection were also high in the other group. So this was the safety profile of the study from the Islamabad, which showed the similar reduction, who had the similar low risk of UTIs and urinary problems and genital tract infection of 1 and 1.2% only. The risk of the decay or the euglycemic decay, yes, it is a concern, as we know that this medication has been tried before coming to our country. Now we know that in which patients there are high risk. The studies in the 40,000 patients showed no clear signals of decay, while in the Canvas study, it has some risk of decay. And in the other study with the empagliflozin, the decay rate, or the declared studies, it was 0.1%. And these risks can be reduced if you do not give this medications into type 1 patients, or the patients who are type 1 wrongly diagnosed with type 2 and the ketosis prone type 2 diabetes. Cardiovascular renal protection, the Canvas studies and the EMPAREX studies, apart from good control of HbA1c, there was a further reduction of HbA1c risk of cardiovascular of about 38%. There is similar risk reduction of progression of CKD in the DAPA as compared to the placebo in the declared trial. So in the heart failure and the MACE reduction, the SGLT2 inhibitors had less hospitalization rate in the heart failure as compared to others, and the 3-point MACE was reduced in the SGLT2 inhibitors as compared to others in the other. So this was the cost effectiveness. This study was a randomized control study was done in high income countries, where they found preventing the cardiovascular event with the medications where it is very costly. Even in these countries, it was cost effective. So what the guideline says, if the patient having a atherosclerotic cardiovascular diseases, we can consider GLP-1 agonist or either SGLT2 inhibitors. But if the patient having a heart failure or CKD predominant, the SGLT2 inhibitors should be preferably given. And this and is the type 2 diabetic patients having a overweight, we need to lose the weight, the SGLP1 and the SGLT2 inhibitors can be considered. This is the first time in the history of any guideline. From last 60 years, the metformin was the first initial agent, the first agent. But European Society of Cardiology suggests that if the type 2 diabetic patient who is drug naive, having atherosclerotic coronary vascular, is high risk or very high risk for coronary vascular disease. SGLT2 and GLP-1 receptors agonists be the first line medications in these medications. This is the first time in the history, 60 years history of metformin, which remained first line for the past 60 years. But here, if this drug is this risk is not present, then the metformin and other can be considered. So these are the effects we discussed. Effective cost we discussed, well tolerated and safety, cardiovascular protection, it is losing weight, oral once daily available. Yes, it is cheap in Pakistan. It can be as cheaper as to the modern sulfonylurea if you would compare it in our region. So ignoring evidence leads to avoidable harm, and failing to admit our uncertainty means don't get better evidence. It was said by the Margaret McCarthy. Thank you very much.